So in this second part of still the early embryonic series, we are going to talk about the process of implantation, but we'll also look at the disorders of implantation. Remember, when the first week ends, implantation, the conceptus is ready for implantation. Just a review of what we learned in the first week of development is that the conceptus is being propelled from the site of fertilization toward the site of implantation. During that movement, there are some morphological changes that the conceptus undergo. We say that it will become the zygote first, then 2-cell stage, then 4-cell stage, then morula, and then blastocyst. At the end of the first week, we have a structure which we call the blastocyst. And the blastocyst has 2 cell populations, the inner cell mass, embryoblast, and the outer cell mass, trophoblast. These are the parts of the blastocyst. That's the inner cell mass, which is the embryoblastic tissue. This is the outer cell mass, which is the trophoblastic tissue. We also learned that this is the blastocyst cavity. This is the embryonic pole, which is used to lead the way during the hatching process. And this is the embryonic pole, which is now going to lead the way during implantation. So when the first week ends, we are ushered into the second week. What happens in the second week? During the second week of development, the blastocyst will implant. And so we will now establish the pregnancy. Remember, initially the woman had conceived, but we cannot say that she was pregnant. But when implantation takes place, then the pregnancy is established. That will be the subject matter of this class. However, the other things that also take place during the second week, there's some morphological changes that take place involving the inner cell mass as well as the outer cell mass. We will not look at them in this lecture. We'll look at them in the next lecture. During the second week, we also have establishment of fetal membranes. Again, we'll not look at them in this lecture. And generally, the second week of development is known as the week of twos. Again, the concept of the twos, we'll not look at them here. I've just put these concepts here so that you understand that even as implantation is taking place, many other things are also taking place. But because we are splitting this lecture, we're not having those ones here. In this lecture, we're just going to focus on implantation. So this is the objective of this lecture. One is to define what is implantation and state its normal site. Then we are going to look at the key steps that take place during the process of implantation. We will highlight some critical hormonal changes which take place during the process of implantation. And lastly, we'll explain some conditions which are due to abnormal implantation process. So let's start with the first one. Let's define implantation and state its normal site. By definition, implantation is the process by which the blastocyst attaches itself and also embeds itself into the endometrial lining of the uterine wall. Well, I am underlining endometrial lining because that's a normal site. Sometimes you may have it implanting on other sites rather than that, and we are going to talk about that shortly. The commonest site in the uterus where the blastocyst will attach itself at the upper parts of the uterine segments, or what we call the fundus of the uterus. The process of inversion and embedding that occurs during implantation is done by the outer cell mass of the conceptors. It is the trophoblasts that invade the maternal tissues. Now that we've talked about implantation taking place in the fundus, perhaps a good time to just tell ourselves about the parts of the uterus so that we are familiar with what we're talking about. So this is the uterus. This is the fundus of the uterus, which correspond with that one. This is the body of the uterus, which correspond with around there. And this is the cervix, which correspond with that part. The junction between the cervix and the body is called the isthmus of the uterus. Don't confuse it with the isthmus of the fallopian tube. And this point where the fallopian tube attaches is called the corners of the uterus. So we are saying that the conceptors attaches on the fundic side, so we'll expect it to be attaching somewhere here. If it attaches there, then we call that one fundo-anterior. And if it attaches there, we call that fundo-posterior. It can either attach fundo-anteriorly or fundo-posteriorly. In terms of the cross-sectional anatomy, histological layers of the uterine wall, remember uterus has 3 layers. The outermost layer is called the perimetrium. The middle layer is called the myometrium, and the innermost layer is known as the endometrium. The myometrium is the muscular layer. That muscular layer contains large blood vessels, as we can see here. That layer of blood vessels within the myometrium is called the stratum vascularis. So in this image, we see the blood vessels running within the myometrium there. That will be the stratum vascularis, the vascular layer. From there, the other blood vessels which go to the endometrium, these are the ones that are usually affected during menstruation. Remember that the endometrium has 2 parts. The stratum basalis, that layer is the one that remains when menstruation takes place. And stratum functionalis, this is the one that is shed off when menstruation takes place. During implantation, the conceptors will burrow through the stratum functionalis up to there. The junction between stratum functionalis and stratum basalis. That is the normal extent of the burrowing. Okay, I want to give you a question. The question is projected again. I want you to think through it and make a decision around it. You have 30 seconds. Now we can proceed. Having talked about what implantation is and talked about the normal site of implantation, let's now outline the key steps that take place during the process of implantation. One of the first things that must take place is actually the hatching process. So I consider hatching the first event towards implantation, because if the blastocyst does not hatch, then there will be no implantation. Remember, hatching actually takes place towards the latter end of the first week of development. And that means that actually implantation begins at the end or towards the end of the first week of development. But most of the events will then be carried through the second week of development. We defined hatching as extrusion of the blastocyst from the shell of the zona pellucida. And we said that during hatching, the abembryonic pole of the blastocyst is the one that leads the way. Hatching occurs when the blastocyst arrives within the endometrial cavity, so usually around day 5, day 6 there. As you can see in this image, as the shell of the zona pellucida is the blastocyst, and it's the abembryonic pole that has led the way. After the blastocyst has hatched, it will then attach onto the endometrial lining. So we call that attachment. The blastocyst attaches onto the endometrial lining using the embryonic pole of the blastocyst. The site where the blastocyst will actually attach will determine where the placenta will actually be formed. The site of attachment determines the site of placentation. Normally, as I told you, this attachment will be in the upper part of the uterine segments, and so most of the time the placenta will be fundoanterior or fundoposterior. After the attachment, there's a layer of the trophoblast that now differentiate. Or let me put it this way. The trophoblast differentiates into 2 layers after the attachment. There's an outer layer where the cells don't seem to have definite cell boundaries. You see a nucleus, you see another one, and you don't see a boundary. It appears like the cells are fused. We call that layer the syncytial trophoblast. The term syncytial from the word syncytia means fused or uniform or together, kind of. So this is the syncytial trophoblast. But there's also another layer of the trophoblast where we are still able to see the cell boundaries. That is what we call the cytotrophoblast. So the trophoblast differentiates into 2 layers, outer layer called syncytial trophoblast and inner layer called cytotrophoblast. At the implantation site, we have the syncytial trophoblast forming, and that is important during implantation because this syncytial trophoblast invades the endometrium. It is the layer that actually burrows through the endometrium. Other than burrowing through the endometrium, the syncytial trophoblast also participate in secretion of a hormone called the human chorionic gonadotropin. You can call it HCG. What is the role of HCG? I know it's tempting for you to say that HCG is used to diagnose pregnancy. Well, that's more of a clinical application of the biology. The role of HCG is to maintain the corpus luteum so that corpus luteum can continue to produce progesterone. We are going to talk about that shortly when you talk about the hormonal changes. So for now, I want you to capture that after the attachment, the syncytial trophoblast forms. And so the syncytial trophoblast help to burrow the endometrium. And so the process of burrowing, or I'm calling it invasion, and embedding will go on. As you can see, the conceptus is now entering the endometrium. This is the syncytial trophoblast. Now it has expanded, and that's the cytotrophoblast. How far will it reach? the junction between the stratum functionalis and the stratum basalis is a normal extent of the burrowing. During that burrowing, and as the syncytial trophoblast continue to become big, there are some vascular channels which appear within the trophoblast, especially within the syncytial trophoblast, like these ones. These vascular channels are known as the trophoblastic lacunae. So there are vascular channels that appear within the syncytial trophoblast, trophoblastic lacunae. These trophoblastic lacunae communicate with similar vascular channels within the endometrium, which we call maternal sinusoids. So we have maternal sinusoids and we have trophoblastic lacunae. These communicate. They contain blood, and so they're a form of communication, which means a form of exchange of substances. This primitive form of exchange of substances before the placenta is established is otherwise known as the primitive uteroplacental unit. So we have establishment of the primitive uteroplacental unit at this point because of that communication, exchange of substances between the trophoblastic lacunae and the maternal sinusoids. Now remember that the blastocyst created a defect on the endometrium when it was burrowing. That defect that it created needed to be repaired. And so that's the last step towards, during implantation, the defect that was created now repairs itself. The repair process will first occur by some fibrin clot, and then you'll have the epithelium regenerating to cover the conceptus. Great, so that's the process of implantation. After the epithelium has repaired, we are now sure that implantation is complete. So remember, I defined it as the process of invading the endometrium during, okay, maybe that one is wrongly coined, is the process by which the blastocyst invade the endometrium, and that the endometrium is invaded via the trophoblast. The trophoblast layer is the one that invades the endometrium during implantation. Generally, the process of implantation will begin on the 6th day after fertilization, which means towards the end of the first week. And in general, it's completed by the 13th day after fertilization, almost the end of the 2nd week. We generally say by the end of the 2nd week, implantation is complete, so that by the end of implantation, the conceptus is 2 weeks old. I told you that the site of implantation will determine the site of placentation. Some women may bleed a little, some spotting when implantation is taking place. We call that implantation bleeding. It may occur around that time of implantation. Now that spotting can be easily confused with normal menstrual flow, but you need to distinguish the two. How do we distinguish the two? Implantation bleeding is just a spotting, and so we expect it to last just less than a day. Remember, menstrual flow will last for some 3, 4, 5 days, and of course it's heavier. But the confusion arises because this time that this woman is seeing that bleeding, is almost around the same time that this woman was expecting her next menstrual flow. Because you're talking about 2 weeks after conception, 2 weeks after ovulation. And that's the time that she's expecting her next flow. So a woman can easily confuse this with menstrual flow. So if you're asking a woman, then they tell you, if you ask them the last normal menstrual period, then they give you a date. It is important that you ask, how long was that flow? If they tell you just a spotting, then maybe that was implantation bleeding. Right, another question for you. Projected. Take some 30 seconds and think through it. Okay, we can proceed now. So let's look at the hormonal changes that take place during implantation. Before we look at those hormonal changes, let's understand some of the hormonal changes that occur before implantation. Start from the ovary. We say that the follicle stimulating hormone stimulates the ovary so that we have follicular development. And so during the follicular phase of the ovary, the levels of estrogen also rise. And so we call that the estrogen phase. It reaches a point when we have a dominant follicle that will then be ovulated. Around the time of ovulation, we know that we have a positive feedback mechanism that causes luteinizing hormone surge. And that is what will eventually lead to extrusion of the oocyte from the ovary in the process of ovulation. After ovulation, the structure that remains in the ovary is called the corpus luteum. The corpus luteum produces progesterone, high levels. And so we call that luteal phase the progesterone phase, as you can see in that image. But the corpus luteum does not last forever. The corpus luteum lasts for only 11 to 14 days. Let's call it 2 weeks. So because the corpus luteum is going to involute, it means that the levels of progesterone are going to go down, as well as the levels of estrogen. That has implications on the uterus. Let's see how. So these are the hormonal phases of the ovary on your left-hand side. And these are the endometrial events on your right-hand side. When estrogen levels are rising, that causes proliferation of the endometrium. When the levels of progesterone are high here, progesterone phase, that causes endometrial glands to develop and the blood vessels to become more, so we call the secretory phase. But when the corpus luteum disappears, and so the hormonal production of the ovary go down, both for estrogen and progesterone, because of that hormonal deficiency, we have menstruation. So this is what happened before implantation. The decline of the ovarian hormones will lead to menstruation. In a month that the oocyte has been released, ovulation has taken place, but the oocyte is not fertilized, the corpus luteum will only last for about 2 weeks. Because the corpus luteum involutes, the hormonal production of the ovary also go down. So we are looking at the levels of progesterone and estrogen. We have a decline in the levels of estrogen and progesterone. Because of the decline in the levels of these ovarian hormones, especially progesterone, the secretory phase of the endometrium cannot continue. It will enter into ischemic phase, which will then be followed by the menstrual phase. If you remember the lecture on female reproductive cycles, that should be clear to you. So this is what happens when there is no fertilization and there's no pregnancy. It's a repeated thing. How about that time now that the oocyte that was released was fertilized and implantation has taken place or is taking place? What are the hormonal changes? I told you that the syncytial trophoblast will produce HCG. This syncytial trophoblast that produces HCG is the one that was being used during implantation. So it produces HCG. The role of HCG is to maintain the corpus luteum so that corpus luteum does not disappear but remain in the ovary, which means that continue to produce progesterone and estrogen hormone. Because of that sustenance of the corpus luteum and therefore continued production of estrogen and progesterone, the secretory phase of the endometrium or the luteal phase of the ovary continue. And because of that, menstruation will not take place. That phase that the endometrium enters is what we call the pregnancy phase of the endometrium. So the key point to note here is that when there is implantation, there is HCG that sustains the corpus luteum, so corpus luteum continue to supply estrogen and progesterone, and for that reason, there'll be no menstruation. The corpus luteum of pregnancy does not also just last forever though. Usually it lasts for about 2 to 3 months. After the 2 to 3 months, the corpus luteum of pregnancy will also involute. That does not mean that we no longer require estrogen and progesterone. The main thing here is that now at this point, the placenta has established, and so it is able to produce its own progesterone and estrogen that sustain the pregnancy. So those are the hormonal changes which take place during implantation. Now let's do the last part of the lecture. Let's look at some of the conditions which occur due to abnormal implantation process. One of the things I want to talk about is ectopic pregnancy. Ectopic pregnancy is implantation, hence pregnancy, outside the endometrial cavity. Remember, I told you that the normal site is the endometrial cavity. So if the conceptus does not implant within the endometrial cavity, it is outside the endometrial cavity. We call that ectopic pregnancy or ectopic gestation. Ectopic gestation could be within the ovary, so we call that ovarian pregnancy. Could be in the abdominal cavity or peritoneal cavity, we call that peritoneal or abdominal pregnancy. It could be within the fallopian tube, we call that tubal pregnancy. Could be in the cervix, and we call that cervical pregnancy. The commonest form of ectopic pregnancy is tubal pregnancy. Over 90% of ectopic pregnancies are actually pregnancies within the fallopian tube. Now, what's a normal outcome of that type of ectopic pregnancy? Fallopian tube is relatively small, significantly so actually. And so it can't sustain a big baby growing. So if you have pregnancy in the fallopian tube, as the pregnancy grows, it will rupture the fallopian tube. So tubal rupture is one of the outcomes. And if the fallopian tube ruptures, then there could be some bleeding from the mother, bleeding from the implantation site. And that significant bleeding will then mean that the embryo will not be viable. So it will actually lead to embryonic demise. If you have tubal rupture, you'll have embryonic demise. And remember also the life of the mother may be at risk to some extent, depending on how much blood she loses when that tube ruptures before it is picked by a clinician, and so some intervention done. So tubal ectopic pregnancy is not something to joke around with. Usually, when we detect tubal ectopic pregnancy, you'll be told that the management is to terminate that pregnancy because of the outcome we've talked about. Now, the other disorder of implantation is placenta previa. Placenta previa refers to a placenta that has formed in the lower parts of the uterine segment, like in these images you're seeing here. It's a low-lying placenta. Well, there are different degrees of placenta previa, but let's look at this one, which we call grade 4, where the placenta is obliterating the internal os, the cervical canal. If this baby is to be born, this placenta will have to separate first and maybe come out before this baby can come out. What's the danger of that? First of all, there'll be a lot of bleeding from that site of separation, even before the baby is born, and that is what we call antepartum hemorrhage, bleeding before delivery of the baby. Other than that, if you separate the placenta before the baby comes out, it means that you're actually cutting off oxygen supply to the baby. And so when this baby comes out, chances are that this baby will not be alive. It will be a stillbirth. So again, the normal management of this kind of placenta previa, which we call grade 4 placenta previa, is basically a cesarean section so that the baby is delivered from this side. Okay, the other disorders of implantation is where the conceptus has invaded too deep into the uterine wall. Let's use these images to remind ourselves of the layers of the uterine wall. So the endometrium, myometrium, and perimetrium. We say that the endometrium has two zones, stratum functionalis and stratum basalis. The normal implantation is where the placenta is reaching that junction there, because that is where the invasion reached. The junction between stratum functionalis and stratum basalis there. So you may have a scenario where the invasion was beyond the whole of the endometrium like this. We call that placenta accreta. You may also have a scenario where it invaded too deep into the muscular layer. That's what we call the placenta increta. And the last one, and most extreme, is where it goes through all the layers of the uterine wall. We call that placenta pacreta. Of course, this is with increasing severity. What's the problem with this kind of placentation or placental attachment? Such placenta will not come out easily after the baby is born. So it will give us what we call retained placentation. When the placenta refuses to come out, yet the baby has been born, we call that retained placenta. And it has its own challenges. One of them being the risk of a lot of bleeding after delivery, what we now call postpartum hemorrhage. Okay, one last thing is that you may have early pregnancy loss, or you call it early pregnancy failure. The term pregnancy loss, sometimes called miscarriage or spontaneous abortion, is generally defined as a non-viable pregnancy up to 20 weeks of gestation. So basically the first half of the pregnancy, if the baby is not viable, we are looking at the viability of the baby. If the baby is not viable, which means the baby is dead, basically, that's a pregnancy loss. So you can call it miscarriage or spontaneous abortion. So when do we call it early pregnancy? We call it early pregnancy loss if this loss is occurring in the first trimester. Remember, you can divide pregnancy into 3, the first trimester being the first 12 weeks plus 6 days. That's the first trimester of pregnancy. And the dating system I'm using right now is the dating based on the last normal menstrual period, which means that when we say that implantation is completed by the 2nd week, according to pregnancy dating, now that is 4th week. Remember, you need to add 2 when you are looking at embryonic or conceptual dating, and you're looking at the pregnancy dating in terms of the last normal menstrual period. Okay, now the commonest type of early pregnancy loss would be, so the commonest type of pregnancy loss will be early pregnancy loss. The risk factors for early pregnancy loss is numerous. Maybe there's some aneuploidy syndromes. Remember the trisomies and the monosomies, those ones could lead to early pregnancy loss. Some of them could be hormonal disorders. For example, if the progesterone levels are just very low, maybe this human chorionic gonadotrophic hormone is not supporting the corpus luteum adequately, and so the levels of progesterone are low. Maybe there's some infections. Maybe the woman conceived and she had an IUCD, so it's still inside there. Maybe she has taken some drugs, these drugs that you can actually administer. Maybe it's a substance abuse, maybe alcohol, cigarettes. Perhaps the woman is just super stressed, obesity, diabetes. The list is actually endless. But at least remember the first 3. These are the common causes of early pregnancy loss, or let me not say cause, but risk factors for early pregnancy loss. The symptoms for early pregnancy loss will be non-specific. So when you see them, you can't really conclude. You may have to do some other tests for it to confirm. But they'll include vaginal bleeding and perhaps some lower abdominal pain, which come from uterine cramping. When you use the term early pregnancy loss, there's some 2 terminologies that you need to be familiar with. And maybe one of them is what applies now and another one we'll use later. So it could be a scenario where, yes, the conceptus is there, but the inner cell mass is non-viable, which means that the embryonic tissue is non-viable, yet the trophoblast is still intact. That is what we call the abembryonic pregnancy. So brought to context, that is actually what I wanted to talk about as one of these disorders. It may happen during the implantation process that you may have an embryonic pregnancy during the implantation process. But again, remember that implantation could be occurring, but there's no enough levels of hormones, and so it doesn't attach properly, it comes out as well. But later on, there's some terminologies that we can also use, maybe now not necessarily during the implantation itself, but after implantation has taken place. Maybe by imaging, we see that there's pregnancy and we see the baby, but we don't see the cardiac activity. The heart is not beating. So when the heart is not beating, we call it embryonic demise or fetal demise, depending on the timing. You know, the fetus will be an older one and the embryo is a younger one. So the term embryonic demise or fetal demise still constitute part of what we call the early pregnancy loss. There's a term that you may come across in your books. We call it blighted ovum. That term is a historical phrase, but it basically refers to embryonic pregnancy. Pregnancy where the trophoblastic tissue is still there, but the inner cell mass is non-viable. And so that baby is not going to be proceeding. Great, these are the disorders of implantation. And so we will stop there. The next lecture will be on the events of the second week of development, now excluding the process of implantation.